Hello, welcome to the George and Fahey Center for Healthcare Innovation's January Patient Engagement Lunchtime Learning Series for the 2025-2026 academic year. Today's session is drawing out experiential knowledge, asking the right questions in patient and public engagement with Carolyn Shimon and Susie McLeod. My name is Maxa Sawyer, one of the patient engagement consultants on the patient engagement team at CHI, and I will host the session today. The PELL series is accredited by the Royal College of Physicians and Surgeons of Canada as a group learning activity. It may also be eligible for credits toward requirements of other professional bodies. We would like to welcome our speakers, Susie McLeod and Carolyn Shimon. Carolyn and Susie will be sharing their PowerPoint presentation that contains resources at the end. And I would now like to welcome the speakers to share a land acknowledgement, followed by their presentation.
Thanks so much, Maxa, for the introduction. Welcome, everyone. Today, we're going to explore lived and living experience versus experiential knowledge and how thoughtful question framing strengthens both research and health systems decision making. So to begin with, I really want to acknowledge that myself, Susie, Maxa, and the Center for Healthcare Innovation and Shared Health um, are located on the ancestral and current day lands and waters of the Anishinaabe, Inninewak, Assinininewak, Dakota Iote, and Dene Suline, and on the national homeland of the Red River Métis. And in northern Manitoba, we acknowledge the ancestral lands of the Inuit, and we gratefully acknowledge that our water is sourced from Shoal Lake 40 First Nation. And we respect the spirit, intent, and language within the treaties that were made on these lands and acknowledge the harms and mistakes of the past and present. These lands carry the histories, laws, and knowledge systems of the First Nation, Inuit, and Métis people who have cared for them for generations. And in health systems and health research, we often talk about evidence, expertise, and data, but we also need to recognize that some of the oldest and most enduring forms of knowledge are grounded in lived experience, relationship, and place. Indigenous knowledge systems remind us that knowledge is not abstract or neutral. It is connected to land, community, and responsibility. So, as we talk about experiential knowledge, power, and how we invite people to share what they know, we acknowledge that colonial health systems and research institutions have too often dismissed, extracted, or harmed Indigenous peoples and other marginalized communities. So this history shapes whose voices feel safe to speak, whose knowledge is believed, and whose experiences are acted upon. Our commitment in this work is not just to invite participation, but to create the conditions of safety, respect, and accountability that allow knowledge to be shared without harm and used in ways that support healing, equity, and better care for all. So just to start out, to introduce ourselves, my name is Carolyn Shimon. I'm the Provincial Patient and Public Engagement Lead for the George and Fahey Center for Healthcare Innovation and Shared Health. And in this role, I lead the development and implementation of patient and public engagement strategies across both health research and provincial health systems. And I'll turn it over to Susie.
Hi, everyone. My name is Susie McLeod. I am a patient engagement consultant with Shared Health, and I've been in this role for just over 4 years. But I do have over 30 years of experience in the healthcare system that spans across long-term care, acute care, and community health, primarily in volunteer and community engagement. And my primary work as a patient engagement consultant is to coordinate the Shared Health Patient and Family Advisor Network, which includes recruiting patients and family members with lived experiences within the healthcare system, as well as public members interested in the healthcare. And I match them to engagement opportunities within the healthcare system. In addition to this, I have a degree in recreation studies from the University of Manitoba, as well as a certificate in health services leadership from Red River College. So, Carolyn and I both work for Shared Health and the George and Fay Center for Healthcare Innovation, and we do not have any perceived, potential, or real conflicts to declare. And so for our session today, our learning objectives that we've listed here will allow our participants to be able to differentiate between personal stories and experiential knowledge. You will be able to develop engagement questions that draw out insightful relevance or insight relevant to research and health system planning. You'll also be able to apply practical strategies to adapt question framing for different contexts, whether it's an advisory group or a focus group. And lastly, hopefully be able to practice asking and refining questions to encourage reflection, synthesis, and shared learning. And so with this, let's talk about why this matters. And so asking the right question in engagement matters as it improves relevance, quality, and impact of why you're engaging. We don't want, it really helps us move beyond tokenism, and we really don't want questions that you ask to appear that we are checking off a box on a list and that the responses will be filed on a shelf and not used. We really want is engagement that moves to shared decision making. And personal stories are important and they do have a place in engagement, but actionable insight that's derived from those personal stories really does require intentional questions. And so many teams involve patient partners and advisors, but they don't always know how to draw out that insight that shapes decisions. And so understanding experiential knowledge, which helps us ask better questions, is what we will be addressing today. So let's look at this in more detail. So
some of the key concepts to begin with is lived and living experience. So lived experience is what someone personally goes through. And when we say living experience, it emphasizes it continues to evolve. So lived and living experience is firsthand personal experiences of illness, of care, of services, or health systems. And it's often emotional, embodied, and specific to time, place, and circumstance. So what it might look like when we're engaging in health system engagement, it might look like when I was discharged from hospital, I didn't know who to call with questions. I felt anxious and unsupported. And when we're doing engagement in health research, it might sound like participating in the study felt overwhelming because I didn't understand what was expected of me. And why lived and living experience really matters is that it grounds the work that we do, whether we're health researchers, whether we're health systems decision makers, or health systems workers. It helps ground the work that we do in real lives. It helps us build empathy and understanding, and it really helps teams understand the patient journey and some of the unmet needs.
So patient and family members get involved as advisors or partners because of their lived experience. And we want to ensure what they are sharing is most meaningful to staff or whoever the audience is. And within Shared Health, in conjunction with a patient and family advisor, we have created a 4-week training series called Sharing for Impact. And this training has been adapted from CanSolve CKD Network and has been supplemented with Shared Health content. And the focus of this training shifts from chronological storytelling to focusing on specific moments of care and a call to action that connects with the audience. And so we talk about what it's like to share and discuss what fears and the impacts of sharing has on them. We also move people along to reflect on their experience and eventually plan, write, and present a 10-minute story at the end of the training. From this training, we have also launched a speaker series where participants from this training can practice sharing their story in a safe space amongst their peers before doing so with staff. We have heard from audiences who've heard our patient stories that they have shared how meaningful the stories are and how they've helped shape their decisions and their work moving forward. The Sharing for Impact training series helps advisors share their personal story with a call to action that moves to actionable system level insight, which really does segue into our next slide regarding experiential knowledge. So what are some of the key concepts of experiential knowledge? It really is insight that's derived from that lived or living experience. And it allows people to be reflective. They analyze their experiences so that it's transferable either to health system or to health research. And that experiential knowledge emerges through discussion, reflection, or that collective meaning and making. So on our next slide here, we have some examples of what experiential knowledge might look like in health system and health research. So in the health system example, someone would say, many patients experience confusion after discharge. There's a system-wide gap in follow-up communication that could be addressed through clearer care coordination. So this really reflects that rather than a patient commenting on a specific item that happened to them, rather they are going to be reflecting on that experience, recognizing any potential barriers or challenges that they may have encountered, and then they make a comment and a recommendation that's transferable that helps improve that situation. And similarly, the example in health research would read or would come across as across several studies, people like me struggle with rigid appointment schedules. Flexible participation options could improve recruitment and retention. So you can see where they've reflected on their own experience, but they've also have made a recommendation in terms of what can be improved for that situation. So why does this matter? It matters because it allows us to have actions that can implement or influence decision making. It informs our design, it informs priorities, the implementation and evaluation of initiatives and projects and research. And it also does support co-design and shared ownership, which is what we are really working towards when we're engaging patients and families and the public.
And so just, oops. And so just looking at some of the key distinctions at a first glance. So when we're talking about lived and living experience, we're talking about the focus is really on personal events and emotions. Whereas when we're talking about experiential knowledge, the focus is more on patterns, insights, and system understanding. The nature of lived and living experience is often individual and specific, whereas when we're talking about experiential knowledge, we're talking the nature is more transferable and reflective. The value of lived and living experience is that it humanizes the work that we do. And for experiential knowledge, it helps improve design and decisions, both in health systems and in health research. And the role in engagement for lived and living experience is really sharing perspectives. And in experiential knowledge, the role is partnering, designing, and co-design. And as Susie had mentioned before, both are extremely valuable. Our goal is to create conditions for experiential knowledge to emerge. And why this matters for both systems and research. Both forms of knowledge are essential. Using both lived and living experience and experiential knowledge strengthens health systems and health research, making them more equitable, relevant, and impactful. Lived experience or lived and living experience connects the work that we do to real lives, and experiential knowledge helps teams design better systems and stronger research. So really, it's all about intentional question framing so that we can support meaningful partnership. It's important to note, though, first of all, some of the issues that may arise, and the context in which we are asking questions and sharing lived and living experience. So it's important to recognize that engagement does not happen on a level playing field. Some people carry institutional power, others carry the risk of being misunderstood, dismissed, or harmed. Safety is not neutral. So for many partners, especially Indigenous, racialized, disabled, or 2S LGBTQIA+ partners, sharing lived or experiential knowledge has historically come with consequences. And that's why safety, choice, and consent aren't just nice to have, they are core anti-racist engagement practices. Before asking people to share, we should be asking ourselves, who holds power in this room? Who has been historically ignored or harmed by the system? And what might it cost someone to speak honestly here? So creating safety means more than setting ground rules. It means how we respond in the moment. So safety looks like naming that no one is required to share personal experiences at the beginning when we start doing engagement, avoiding defensiveness when we receive hard feedback, not correcting or minimizing someone's experience, and following up when difficult issues do surface. When we're talking about choice, choice means people get to decide whether they share at all, whether they speak from personal experience or broader observation, and how they contribute, whether it's speaking, whether it's in writing, whether it's in the chat box, whether it's in a one-on-one follow-up later on or via email. And then when we talk about consent, consent means being transparent about why we're asking the question, how the information will be used, what will be documented or shared, and recognizing that consent can change over time. So just because you give consent at the beginning does not mean that you can't withdraw it later on. So without safety, choice, and consent, engagement risks being extractive, even when intentions are really good. And so moving on to framing questions that draw out experiential knowledge. What does this all mean? So patient, family, and community partners bring experiential knowledge. So insights that they've developed through lived and living experience over time, reflection, and engagement across the system. And this knowledge can help improve within health systems. It can help improve service design, quality improvement initiatives. It can help improve policy and patient safety and projects. In health research, this knowledge can help improve study design, recruitment, outcomes, interpretation, dissemination, all of these things. And the way questions are framed determines whether we hear individual stories only or gain insights that can shape better system and research. So even though the contexts differ between health research and health systems engagement, the principles of engagement themselves and the question framing are the same. So in research, we engage folks around study design, recruitment materials, interpretation, and knowledge translation. In health systems, we engage folks in program planning, quality improvement, patient safety. There's a myriad of participatory approaches that we use both across health research and health systems. And of course, when we're engaging in health research, the insight shapes questions and methods and design of the research. And when we're engaging in health systems, the insight helps shapes policies, services, and programs. So some tips for framing questions. How we frame questions either opens the door or quietly closes it. So questions that ask for your story can unintentionally pressure people to disclose personal or traumatic experiences. Instead, we can ask about patterns or system level insights. We can say out loud that people don't have to share personally. We can normalize passing or offering high level reflections. And this shifts the engagement itself from storytelling on demand to respectful knowledge sharing. So, drawing out experiential knowledge across the work. So, at the planning and design stage, in health systems engagement, we might ask a question like, what should we consider early so this program works for patients long term? In health research, we might say, what should researchers think about before finalizing the study design? In implementation, when we're engaging in health systems work, what usually causes frustration or confusion once services are rolled out? Implementation in health research, we might say, what typically causes people to drop out or disengage from studies? In evaluation and learning, in health systems engagement, we might say, how do patients know if this program is actually helping? And in health research, we might say, how should results be interpreted in light of real world experience? And then finally, in communications within health systems, we might say, what makes system communication feel respectful and trustworthy? And then in health research, we might say, how should findings be shared so they feel useful and not extractive? So again, here are some more lovely examples of how you can possibly frame some questions on the health research side. From your experience, what are some common challenges people face when navigating this service or program? What tends to break down when patients move between care settings, so hospital to home, primary care to specialty care? This one is actually a classic one that works really well. So I just said worked well, but it's what has worked well or not well when health system teams try to involve patients in decision making. But that's something you can use in a lot of what works well, what doesn't work well, and have conversations, getting people to reflect on their lived experience and what they might be able to more broadly help decide as far as things that are working and things that aren't. What do staff often misunderstand about patient or family needs in this part of the system? And what would make this service feel more accessible, respectful, or safer? And then in health research, you can also start with something like based on your experience. This is always a great way to introduce the idea that you're going to be reflecting on your experience, but bringing forward some recommendations or actionable items. So based on your experience, what might make participating in a research study easier or harder for people in similar situations? What outcomes matter most to patients and families in this area, and which ones are often overlooked in research? What barriers might researchers unintentionally build into recruitment or consent processes? How could study materials or consent processes be made clearer or more inclusive? And what are respectful and useful ways to share research results back with participants and communities? So a quick checklist for staff and committees and researchers. The first is, does my question invite reflection on patterns and systems, not just individual stories? Am I linking the partner's insight to a specific stage of system work or research? Am I creating space for multiple perspectives and not asking someone to speak for everyone? And have I avoided tokenizing by asking only for the story and instead inviting insight, advice, or recommendations. So again, the quick checklist is, am I asking about patterns and not personal disclosure? Have I made choice and consent explicit? Do people know they can pass or reframe the question? And am I prepared to act on what I hear?
And so our key takeaways for today's session is that lived and living experience is not equal to experiential knowledge, but both are valuable and have a place in engaging with our patients. Thoughtful questioning framing elicits actionable insight. And lastly, that experiential knowledge strengthens research relevance, equity, and health system decisions. And so our final thought for today is that we want to make sure that we are honoring people's lived experiences when we're engaging with patients and families and the public, and that we want to intentionally draw out that experiential knowledge, and that we recognize that better questions equals better outcomes. And so we want to just make sure that people understand that engaging patients is a learning process and it's a skill that can always be practiced and improved. And we hope that you found this session today valuable as you take this into your practice.
We have a list of some references and foundational pieces that helped inform this presentation, and will be shared with the slides later on. And then, of course, we always welcome questions, so you can contact either Susie or myself if you have further questions or want to chat more about this topic. Thanks so much.
Thank you.
Oops, Maxa, you're on mute.
Sorry about that. Um, Thank you to Susie McLeod and Carolyn Schumann for helping us ask better questions when engaging in health systems and health research. Asking the right questions helps us gather important information, prevents tokenism, and empowers the patients in health systems and health research, as well as advancing health equity. Asking the right questions, implementing an anti-racist, choice-forward framework allows patients to give reflective answers that allows us to develop patterns, which provides actionable items for design priorities, implementation, evaluation in health systems, and research. Connecting the work we do to real lives and meaningful partnership, providing us with the opportunity to do better research and develop effective system policy, service, and programs. If you have any questions, please feel free to contact Susie McLeod and Carolyn Schumann. We'd also like to take this opportunity to invite you to join us on Wednesday 18th, 2026, for our February PELL with Sarah Kirby, lead health quality and patient reported measurement at the George and Fay Yee Center for Healthcare Innovation, who will be presenting Beyond Surveys, Patient and Public Engagement versus Patient Reported Measurement. Thank you again, and we hope that you are walking away encouraged to further explore the possibilities of patient engagement in your work. Thank you, Susie. Thank you, Carolyn, and I'm going to stop recording.
Thanks.